So, we're here today to talk about treatments for depressive disorders and also bipolar disorder. I want to just make a note that some of the treatments that we're going to talk about today, both cognitive behavioral therapy and antidepressants, for example, are used not only in the treatment of depression, but in for some of these other disorders as well, like OCD and anxiety disorders. So, where you are in your clinical psych packet should be depressive disorders and bipolar and related disorders. So let's get started. We're going to start talking about cognitive behavioral therapy, which is a type of therapy created by Aaron Beck. It combines the two approaches that you hear in the title, the cognitive and the behavioral approach. The goal of cognitive behavioral therapy is to make a client aware of negative thinking and have them replace those negative thoughts or irrational thoughts with more rational ones. So, for example, in a smoker who might say, "I'll go crazy if I don't smoke," or one more cigarette won't hurt me. Cognitive behavioral therapy would develop kind of more realistic strategy that lets them challenge what they're thinking. Are they really going to go crazy if they don't smoke? And also help them develop more skills or new behaviors to promote higher self-efficacy, which we know is a person's belief in their ability to do things. I want to use an example of cognitive behavioral therapy actually used for individuals who are being treated for obsessive compulsive disorder, which is characterized by obsessive thoughts and then compulsive behaviors they will engage in these behaviors in order to ease the anxiety brought about from these really obsessive thoughts. So, for example, it was used with people with OCD related to hand washing or like a really intense fear of germs, obsessive thoughts about how exposure to any kind of germs or dirt might bring on illness. So they had these individuals, every time they would think about having this need to wash their hands or this compulsion, they'd have them stop, recognize the distorted thought, and remind themselves, this is a result of my brain kind of misfiring. This is a result of abnormal brain activity, which the researchers actually had these individuals observe on a PET scan in the past. So they knew what that abnormal brain activity looked like as they were having that compulsion to wash their hands. When this would happen, in addition to challenging the irrational thought, the researchers would also have these people engage in some kind of alternative behavior for 15 minutes, like gardening or listening to music or something like that. And researchers did find this to be an effective way to reduce compulsions in people with OCD. If you remember back to our last lesson, we were talking about some examples of cognitive distortions. So the cognitive part of cognitive behavioral therapy, again, is just having people recognize these distorted thoughts when they're occurring, have them come up with more rational ways of thinking about a situation, and then also develop healthy behaviors that they can engage in. This is just an example of a worksheet that might be used as homework for a client who is currently engaging in cognitive behavioral therapy. So it has them describe the event, explain how they interpreted the event, how they felt, their emotions and their bodily sensations, and then also evaluate their behaviors. And again, the goal of this is to recognize the irrational interpretations and the behaviors that follow those rational interpretations so that somebody can engage in more realistic interpretations and in healthier behaviors. So on to the biomedical approach, where we talk about things like antidepressant drugs. And again, antidepressant drugs like SSRIs are not just used to treat people with major depressive disorder. They can also be used to treat people with OCD and anxiety disorders as well, among others. So this is kind of a quick overview of SSRIs because we talked about these back in the bio unit. But remember that selective serotonin reuptake inhibitors do just that. They inhibit the reuptake of serotonin so that more serotonin is available at the synapse. And there is a correlation between more serotonin available at the synapse and a lessening of depressive symptoms. Examples of SSRIs would be medications like Prozac and Zoloft. The thing about SSRIs is because we're talking about biochemical changes that are happening at the synaptic level in the brain, they can take up to 4 weeks to take full effect. And this is because they promote neurogenesis, which is the birth of new brain cells, and also an increase in synapses. So this means that, again, it can take a while for these types of antidepressants to work. Because of that fact, some individuals who might be depressed and in need of more immediate relief of their depressive symptoms might turn to some brain stimulation techniques like electroconvulsive therapy, repetitive transcranial magnetic stimulation, and also deep brain stimulation, which is a little bit newer than the others. Electroconvulsive therapy essentially is a seizure-inducing procedure for people who are not responding to antidepressive medications quickly enough. So an individual who's receiving ECT would be brought in and given an anesthetic and also a muscle relaxer to actually prevent convulsions that would take place as the seizure is being induced. So there's a brief electrical current that's applied to the right side of the brain, which induces about a 30 to 60 second seizure. A side effect of ECT is memory loss for the procedure itself and the hours preceding it as well. Even though this technique has been used for decades, researchers are still not exactly sure of why it works in lessening depressive symptoms for many people. They're not sure if it's because it calms some of the neural centers that are active in depression, or if there also is some evidence that it might promote neurogenesis in both the hippocampus and the amygdala. Transcranial magnetic stimulation is a little bit different. The person is wide awake as pulses surge through a magnetic coil that's held close to the skull. There's also not a conclusive understanding of how this works, but they believe it, again, may be energizing the left frontal lobe, which is involved in, or rather inactive, during periods of depression. There's some evidence that suggests that it increases long-term potentiation, which is the strengthening of connections at the synaptic level. Deep brain stimulation is a newer technique that the verdict is kind of still out on. They're still doing research to see, is this in fact better than placebos? It targets the frontal lobes and the limbic system to inhibit negative activity that occurs in those areas of the brain. There is research showing that in about 30% of people who have deep brain stimulation that they respond well to it, but we're still unsure if it's better than a placebo. So the treatment of bipolar disorder, this is a little bit trickier than the treatment of depressive disorders, because you've learned that bipolar disorder is really, there's two different things going on. There is a period of where an individual will experience depression, but then that's often followed by times of mania. So for example, in treating bipolar disorder with an antidepressant, you may risk sending a person into a manic period. So for this reason, mood stabilizers are used. Mood stabilizers like lithium can level the emotional highs and lows that people with bipolar disorder experience. Lithium has been shown that 7 in 10 people will benefit from a long-term daily dose of lithium. It has been shown to prevent and to ease manic episodes. It, in some studies, has been correlated with lower risk of suicide, 1/6 the risk of suicide as those not taking lithium. However, people who are on lithium need to go for regular blood testing because it can be toxic in large quantities. There are other mood stabilizers as well, but the one that you should definitely be most familiar with in the treatment of bipolar disorder is lithium. I just wanted to briefly mention at the end of this that there used to be psychosurgeries. Psychosurgeries used to be much more common than they are today. I think we talked earlier in the year about lobotomies, where essentially they would stick an ice pick-like instrument through the inner corners of the eye of an individual and sever the connections between their frontal lobes and the emotion controlling centers of the brain. The idea, and this was developed in the 1930s, the idea was that they were going to disconnect emotion from thought. I mean, this was really a barbaric procedure that was used from the 30s through the 50s that's no longer used. There were tens of thousands of these procedures performed between those 2 decades. It would leave an individual permanently lethargic with flat affect, meaning an inability to express emotion, uncreative, immature. Today, psychosurgeries are not being used to this extent. There are microscale surgeries that are sometimes used, for example, in people who live with epilepsy. There's sometimes surgeries done in order to prevent the spread of seizures. We kind of talked about that a little bit earlier in the year with split brain patients. And there's also for people with OCD, with severe OCD, sometimes MRI guided precision surgeries that target some of the circuits that are involved in people with severe OCD. But generally speaking, these types of psychosurgeries are a last resort.